Okay, can I start?
Yes.
Yeah. Okay, good afternoon, good morning, good evening to all of you, wherever you are. This is actually a teaching session for year 4 of University of Baba Rahman Medical Faculty. And I will, that's the Utah logo there, and I will try to cover this in as short a time as possible. Now, psychiatric emergencies in general hospitals and non-psychiatric settings are not addressed very well in the teaching of medicine. Unfortunately, because of a long line of reasons, psychiatry has always been thought to be something related to mental hospitals, emergencies in mental hospitals, or emergencies that end up in mental hospitals. Or now, in Malaysia, in the last about 60 years, we've had general hospital psychiatric units. Today, there are over 50 general hospital psychiatric units. In 1957, when Malaysia became independent, we did not have a single general hospital psychiatric unit. So in the last 60 years, many units have been built up even in smaller hospitals, district hospitals, not just general hospital, large hospitals. As you know, in Malaysia now, hospitals are not called general and district and so on. It is called Hospital Tampin, Hospital Kolapila, something. And some of them are named after very famous people, the sultanas of certain states. So in the larger hospitals, like Hospital Selambang, Hospital Johor Bahru, these hospitals have had psychiatric units for the last 50 odd years. And so whenever there's a psychiatric problem, immediately they call for the doctor from the psychiatric unit, and he or she manages that. Now, this has gone on for a long time, and now there are many general hospital psychiatric units or district hospital psychiatric units. For example, in Syria and in Sarawak, there is a psychiatric unit, but outpatient only, with 3 inpatient beds in the medical ward. So these are smaller units, no official large 20 or 30 bedded unit. They are smaller units. But there's a psychiatrist, a qualified psychiatrist is there. Syrian didn't have a hospital actually in 1969. Now there's a hospital. So psychiatric problems don't only occur in big towns, they occur everywhere. Rural areas, small towns, everywhere. So every medical doctor and every nurse actually, every state registered nurse or SRN should know something about how to manage psychiatric emergencies because they can occur even in rural clinics. So that's the reason for this brief outline of psychiatric emergencies in general hospitals and anywhere outside of the psychiatric units. A little background to psychiatry in general hospital. Mental illnesses, 90% are not in mental hospitals. This may come as a bit of surprise to you. Psychiatric patients in mental hospitals, very, very small portion of all psychiatric illnesses and problems in the community. In any country in the world, the number of psychiatric patients in the population is around 10 to 15% of the population. In the psychiatric ward, of course, 100% are psychiatric patients. In a mental hospital, maybe 90, 95, even 98% maybe severely ill mental patients. But psychiatric problems also occur in the non-psychiatric settings, in medical, surgical, ONG, orthopedics, ENT, eye. This is what we call liaison psychiatry, where psychiatrist goes to other wards to attend to psychiatric patients referred by other doctors. We usually cannot walk into a ward and say, where are the psychiatric patients? We have to be referred, but the patient is actually in another ward, another discipline. So they refer to us. And this is a very rapidly growing area of psychiatric uh, detection and management. About 20 to 30% of patients in medical, surgical, ONG wards, at least, of general or district hospitals with significant psychiatric problems requiring treatment. So this is in the inpatient wards. In fact, we did a study in University of Malaya way back in the 1980s. And we found that about 65% of patients in the surgical ward had significant anxiety and depression and post-operative problems related to mental illness rather than the actual surgical problem. So 40% prevalence is not rare, but they're not detected easily and very often not managed. Reasons for missing the psychiatry in general wards is teaching of medical students, nurses on patients in psychiatric wards, hospitals, where over 90% are severely psychotic patients, severely ill organic or mood disorders. So the students and the nurses are under the mistaken impression that all the psychiatric problems in the community end up in the psychiatric ward. That's not true. It's not true at all. Only 0.7%, like adjustment, stress disorders, were admitted to one mental hospital in 2011. 3 out of 442 patients were admitted that year, and only 3 had a diagnosis of stress disorders. Stress is in every ward in clinic. Psychosis is mostly in the mental ward or mental clinic. If you learn psychiatry in this kind of setting, in a locked ward or locked psychiatric unit with bars and grills, you saw only the psychosis. If you didn't get a chance to see the non-psychotic, or the psychotic problems that occur in the non-mental setting. Stress management clinics were set up to focus on treatment of patients and teaching of nurses, medicals, on 90% of mental illnesses that almost no one is recognizing or treating. And this is primarily in the primary care. Primary care clinics can be very busy, hundreds of patients every day, and yet their anxiety and depression and stress-related disorders come in, are treated for physical complaints, and go out, and almost nobody detects it. Increasingly, with better training of GPs and primary care physicians, more are being detected. There's now a questionnaire in many hospitals in Malaysia, in the clinics, primary care clinics, which doctors use easily and detect some of these cases. But then again, there are lots who don't use this questionnaire regularly. The World Health Report in 2001 actually recommended that we should actually see psychiatric problems in the primary care and treat them there. But what the mind was not trained to do, because we saw only psychotic patients in the psychiatric ward or the psychiatric hospital, the eyes will not see. And therefore, they are missed. They are missed in the sense that they've got psychiatric problems, not psychosis, anxiety, depression, stress. But they don't go to the psychiatrist because they say, I'm not bad. Even the patients think to go and psychiatrist, to go and see a psychiatrist, you got to be mad. You got to be psychotic. And they say, no, I'm not psychotic. So even the patients associate psychiatry and psychiatrists with psychosis, not the anxiety, stress, and depression and other problems that also trouble them. Mild, moderate, severe. Emergencies in psychiatry are not that common in the accident emergency. If you go to any accident emergency clinic, accident emergency unit of any hospital anywhere in the world, you will not see dozens of psychiatric patients coming every day. No way. They're a very small number. But one psychiatric emergency that you as a doctor or nurse faces is enough to make A&E staff feel very unsure of themselves. They have just lost. They don't know how to manage it. And they immediately think this patient be admitted in the psychiatric ward. They don't think of managing it. They don't even know what it is. So this is the unfortunate failure in our training of medical students and nursing students. Except they understand the basis of the emergencies, presentations, and emergency management, how to manage the patient in a proper way. Basically, the two types of psychiatric emergencies. It's a very simplified way to make you feel less stressed, to begin to understand that there are basically two types. One is psychogenic, more common in the area. Psychogenic meaning psychological origin, emotional problems, psychological stress that bring the patient to the emergency as a psychiatric emergency. And less common are what we call the organic emergencies. They're difficult to spot and manage. Psychogenic emergencies, anxiety-related panic attacks, acute anxiety, coro, not in many other countries, but in the Southeast Asian countries, coro or sexual panic, that the sexual organ is going to diminish and become lost inside the body. This kind of conditions called coro. These are some of the anxiety-related emergencies. Some depression-related emergencies, acute grief, some loss of somebody, loss, mostly loss of a loved one, but also sometimes acute loss of other things like business or whatever it is. Suicidal attempts, parasuicides, failed suicides. These are relatively common. Perhaps I would say that if you see an acute emergency in a A&E setting, most likely it's a suicidal attempt, or what we call parasuicides, deliberate self-harm. And somebody actually tried to kill himself, but failed, and was injured. But we'll talk about this a little bit later. Less commonly, depressive stupor, blank, non-reactive, dehydrated, self-neglect. History will indicate that the person has been gradually becoming withdrawn and more depressed. Parasuicides or deliberate self-harm used to be called attempted suicides. This terminology has changed. It's now called either deliberate self-harm or parasuicides. Parasuicide does not equal suicide. Suicide, the definition that when you attempt to harm yourself and you die, then it's suicide. But if you harmed yourself, usually in a relatively mild way, like took an overdose, took some toxic liquid, or even slash your wrist, the chances of dying are very limited. And these, very different from completed suicides, are also different in the age at which, sex of the person, and the method and the illness and the outcome. Usually follows, the parasuicide follows acute emotional crisis, following emotional turmoil of hours and days, broken relationship, loss of relationship, quarrels, unhappiness over some job-related problem. Usually it's a relationship problem. Usually occurs in females, about 80%. Females parasuicides. With relationship problems, similar patterns worldwide. Even in countries where suicide is very low, like the Catholic countries and in Muslim countries, parasuicide is much more common. Suicides are rare, but more rare than in the other countries with other religions. But definitely the parasuicides are known. Methods used varies quite widely. Poisons, liquids, tablets, medicines in overdose. No matter how trivial, it's a call for help with stress, an emergency. It's an emergency. Do not treat it as a joke. Or you just took 10 tablets. Why did you take 20? This kind of very careless behavior by healthcare professionals is to be condemned. Treat it with all the precautions on an emergency. You know the chances are the person will survive. But it's also well known that a certain proportion, varying from country to country, actually repeat the parasuicide, and this time they die. So every parasuicide is an emergency. History taking is vital. How much? What was the crisis? What was the broken relationship? Previous attempt. Where did she get the poison from or the tablets? Did she accumulate over years? All this indicates more than just a casual, sudden crisis. Maybe this person is suffering from depressive illness, because depressive illness also sometimes leads to parasuicide. Those who are living alone, recent depressive illness, past mental illness, are particularly prone to try to harm themselves. Management in A&E, if such patient comes, and I said it's fairly common in any large general hospital in a big city, you get about 2 to 3 cases every day. So anybody who works in A&E will usually see one of these cases sooner or later, most likely soon. Joint assessment, no substitute. You have to, this is some other place that I worked in, no substitute found for this as a hospital policy. So routinely, the physician, if it's a medical problem like taking tablets, overdose of tablets, there need to be a medical management. Or cutting themselves, stabbing. I had a patient who stabbed himself with a knife on his abdomen. So there, a surgeon has to be involved, or the physician has to be involved in overdoses, taking poisons, and so on. And medical surgical assessment and decision in writing must be obtained. The physician or surgeon must write and say, I've examined this patient and his injury is not life-threatening or no problem. I can manage it when he's in the psychiatric ward or whatever it is. Psychiatric assessment and decision in writing also. No parasuicide should be treated as a casual thing, just see and say, okay, can go home. No such thing. Everything must be put down in writing, because there's a risk of person actually dying, even after taking the overdose, being admitted to a medical ward. I've come across many cases. Patient jumped out of the window and died. So very, very important that everything is recorded in writing. Management in the ward, secure bed, room near a nursing station or bed near a nursing station. Medical treatment, as I said, if there's an overdose, taking kerosene or taking some poisonous liquid, follow up daily or more often by both specialists. Transfer to another unit when cleared in writing. So the patient who stabbed himself was admitted initially to our ward, but eventually were there to explore. The surgeons had to admit to the surgical ward, take the theater, explore and see how deep the injury has gone. And luckily, it did not penetrate the abdominal cavity. Psychiatric management, history gathering from patient, relatives, friends, very important. Very often patient is in a state of not only shock, but deep denial and said, no, it's all a mistake. I thought it was water, it was actually kerosene. How did you drink 1 glass of kerosene? Because the moment you drink it, you know, this is not water, you spit it out. You wouldn't have swallowed anything. So there are many things the patient tries to hide. It's very important to get a history from others, whoever is available. Assessment and treatment. Crisis counseling by psychiatric staff, very important. The psychiatric staff, if the A&E doctor is unable to do anything immediately, you should immediately call the psychiatric staff. Antidepressants take 2 to 3 weeks to work, even in the psychiatric ward. So you have to think some emergency measures, some management with close observation. Social workup, find out what is the background, what's the problem with the family, work, and so on, and follow up even after patient is supposedly better. Psychosis-related emergencies, acute psychosis, schizophrenia. This is elaborate need for going to this in a different section, but just so that you know, psychiatry illnesses commonly seen as psychosis as schizophrenia. Manic depressive psychosis, manic phase of bipolar disorder, talkative, agitated, restless, grandiose, labile mood, depressive phase, self-neglect, suicidal, elderly, maybe dehydrated, especially elderly. Organic related, traumatic, endocrine, toxic, infectious. Head injuries, well known to cause abnormal behavior, end up in the psychiatric ward, like after a motor vehicle accident, motorcycle accident. Admitted in the A&E, and then from there referred to us. Endocrine condition, not so common, but conditions like thyroid, adrenal, also present as emergencies. Toxic due to whatever poisons, including of course alcohol, and infections. Many infections can go up to the brain, typhoid, malaria, many cerebral conditions due to toxins, due to infections. Traumatic head injuries, infarct, cerebral, and cerebral bleed can all cause abnormal behavior and present in the A&E as emergencies with abnormal behavior. And the doctor's awareness is very important. Endocrine with behavior changes, less common. Hypoglycemic, perhaps more common than the thyroid and so on. Hyperglycemic, and then they go into coma. Acute thyroid crisis, hypothyroidism, and adrenal crisis, all do present with abnormal behavior. So one of the differential diagnoses in the abnormal behaviors, has the patient got one of these. Again, history from the relatives very important. As even a diabetic has been an endocrine problem on treatment and so on. Talk to the agitation, behavior changes, alcohol, of course, very common. This very, very common. Usually don't end up with a psychiatrist until the patient needs admission. Alcohol withdrawal, delirium tremens. Even I've come across in the medical wards, patient was admitted sort of incoherent. They knew he was drunk and he was a bit dehydrated, so they put him in the medical ward. In the middle of the night, he climbed out of the window and almost fell to his death. When somebody caught him and brought him back and asked him, what happened? Why did you try to commit suicide? He said, no, I'm going down to buy some cigarettes. He's in the 11th floor of the hospital and he saw the lights there. He had poor cognitive functions and he was not sure where he was. He could see some lights there and he wanted to buy a cigarette. He tried to climb out of the window. So he was having delirium tremens. And luckily he was saved and he was fainting and then referred him to psychiatric care. And the management was done by both the medical and psychiatric doctors. Nowadays, substance abuse, more and more common. Amphetamines, cannabis, all this can also cause behavior changes. Some chemicals and gas, nitrous oxide, also known to cause behavioral changes. Infections with behavior changes, encephalitis, meningitis, malaria, cerebral malaria, typhoid, any acute infection, including septicemia, can cause behavior changes that present as an emergency in the A&E. How do you manage psychiatric emergencies? Most important is awareness. You must be aware that behavior changes may be the beginning of either psychogenic or organic mental disorders. Consider the differential diagnosis to include the psychiatric possibilities and medical possibilities. Don't think it's either or, could be both. Don't panic. Approach calmly, introduce yourself as a doctor willing to help. most patients will respond positively when you say you're a doctor, except the organic mental disorders. Like somebody who's got encephalitis. His ability to recognize you as a doctor may be not so easy. So he might still lash out at you, may hit out at you, and so on. Very often when there's in an emergency, there are patients who are disturbed and all that. Immediately, everybody gathers to look around. They don't help. They just gawk. And they're all watching the fun. First and foremost thing the doctor must do is tell everybody to get out. Approach the patient by yourself in a calm manner. Talk to him, persuade him to come into a room and talk. Why this not wanting others? The more people there are, the more the agitated patient, especially with an organic mental disorder, but also with a psychogenic psychosis, will react to that by trying to be stronger, trying to be more agitated, more violent. Persuade the patient to come to a room, see the patient with a relative if he's there, and talk to them, identify a safe room in the A&E without equipment and without needles and syringes and knives and all sorts of things, which the patient can easily take and attack you with. Every A&E should have a inverted commas safe room. If agitated, restless, explain the need for a medicine to reduce stress, persuade the patient to take the medicine. I've done this many times. Patient is agitated. I can see that he's not able to control himself. I say, look, I think you are under severe stress. You need a sedative to calm yourself down. No, I'm going to do. No, please, this is good for you. I'm the doctor. You mean you don't trust me? Usually when I use the word, you don't trust me? They say, no, I trust you. But they don't want to take them. So to calm them down. Very rarely, very rarely, I have to get 2 or 3 attendants to come and pin the patient down while I give the injection. Very rarely. Most of the time, with persuasion and calmness, you can use gentle techniques, communication skills. And unfortunately, these skills are not taught very often in medical schools. The patient will calm down enough to take the injection. And the injection will take effect. You can even give IV injection like IV 5 milligrams. That will have very quick effect. Options, oral tablets can also be given. If the patient not so agitated, but you're afraid that he might get worse, take some tablet, have a glass of water. In mild cases, you can give lorazepam 1 milligram, diazepam 5 milligram, or moderate oral haloperidol 5 milligrams. Moderate to severe agitation, IM or IV haloperidol 5 milligrams to 10 milligrams, and can be repeated hourly. Not chlorpromazine, please, because it can cause hypothermia. It's quite risky. So, and also drop in blood pressure. So chlorpromazine should not be given IV under any circumstances. IM sometimes can be given IV, very dangerous. I would prefer haloperidol. Restraints policy, if patient is still agitated, you can restrain the patient only at the joints, not on the long bones. Knee joints, ankle joints, wrist joints, and so on. But not. Why? Because the patient may be so agitated. If you tie him by long bones, he might fracture the bones. The power of an agitated patient you have not seen yet. So please, don't. You must be trained to do restraints. Nurses are usually trained, and you can use bandages with soft padding and so on with the cotton wool. Layers of bandage, cotton. Nurses are trained to put on restraints. Always keep a store of essential injections used in psychiatry in stock, readily available in the A&E and also in the wards, of essential tablets for 3 days supply for the patient, because very often the patient, you cannot wait to get the medicine from the pharmacy. You must have a ready stock for 3 days available. So after the patient is considered calmer, tell the family to take the tablets at least 3 days and come back and see us again. And of course, in an emergency, you can borrow from the psychiatric ward and give it to the patient. Psychiatric medical records is kept in psychiatric ward because the patient is an old patient. Please call and ask. Usually they will know. Old patients, they know. You mention the name, they know where to get the details. Why in psychiatric ward? It's a long story. Referral process, always clerk at least half a page. When you need to refer to psychiatry, don't say psychiatric case, please take over. This is nonsense. This shows very poor training. Immediately my question will be, which college did you come from? Personal data, history, main problems, mental state, agitation. Just describe. Patient very agitated, hit out at me, talks nonsense, shouting, using bad words. And able to refer the patient coherently to a psychiatric MO on call, explaining what it is. Just passing the buck is not medicine. Postman or traffic policeman referrals, very risky for everybody, very irritating, poor medical practice, medical legally risky. You might be actually caught to explain why you didn't write any notes. Written notes must be for referral. Lastly, when in doubt, always ask, always call, always discuss. Every hospital has got emergency numbers, doctors on call 24 hours a day, 365 days a year. There's no such thing as a chutira, no such thing. There's always somebody available in every unit on call. Please call. Ignorance is bliss, but a recipe for legal suit in a disaster. Passing the buck is not medicine. If you are ignorant, which you can understand, maybe you don't have much interest in psychiatry and you didn't learn it properly, you're absent during the psychiatry lectures. I can understand it. Always be decent enough as a medical doctor to ask your seniors, ask your superiors for help. Medicine is a lifelong learning process. It's not a shame to learn. Age-old sayings are, it's never too late to learn. Better late than never. It's better to be a young fool than an old fool. So, as the last slide, psychiatric emergencies can occur in any ward, in the A&E. Most can be managed in same ward by basic understanding of psychiatric emergencies and the medication we use and the approach that is required. Thank you.